All right, folks. Well, it's 5 p.m., so let's get started. I'm sure more will continue to log in as we get closer to our presentation. So welcome to the Health Equity Grand Rounds Echo. This is the last of our 6-part series exploring racism in medicine, health equity, and COVID-19 in Alaska. Today's Echo topic is building health equity and envisioning a culture of change, part 2. And today we'll be discussing critical next steps and sharing visions for what building health equity looks like here in Anchorage, in Alaska, and beyond. This Echo is jointly provided by the Alaska Black Caucus and UAA Center for Human Development Echo Project, with support from grant funds awarded by the Municipality of Anchorage, Anchorage Health Department. My name is Erin, my pronouns are they, them, and I'm an Echo coordinator with the Center for Human Development's Echo Project. I'd like to go ahead and invite Deanne Woodard from the Alaska Black Caucus team to open our session by sharing a bit about the vision that's driving this initiative and the purpose of our Echo series. Deanne, over to you.
Thanks, Erin, and welcome everyone. The Alaska Black Caucus is the premier nonpartisan 501c3 nonprofit organization working to assert the constitutional rights of African Americans in Alaska. Recognizing that racism is a public health crisis, which was only amplified by the COVID-19 pandemic, the ABC partnered with UAA's Project Echo to deliver a Grand Rounds style health equity series. Grand Rounds are historically a part of medical education, in which clinical reasoning skills are enhanced under the guidance of expert clinicians. The ABC wants to use this framework to create a forum for Black community members and experts in various fields to connect with healthcare providers, leaders, and trainees in order to address racism in medicine, disparities in COVID-19, and work towards our shared goal of health equity in Alaska. This project is one of many strategies that ABC is using to decrease racism based in health inequities in our state. So thank you so much for joining us tonight on this, our last session of this series. We appreciate your participation and encourage you to engage fully with this presentation, as well as with all of the work around health equity here in the Anchorage area. In particular, thank you to the Hub team members. I want to say that for myself, I serve as the program coordinator or program manager for the grant for ABC, and it has been a joy to work with everyone and see all of the work that has been done through all of the various activities that ABC has hosted throughout this year. So thank you in advance. I do want to give Celeste a moment to see if she has anything she wants to add to the welcome, or perhaps she will defer until the later in the program. But thank you.
Thank you, Deanne. And also, I want to echo those words of a thank you to everyone that has been participating in this full year of work. I do want to invite individuals to the unveiling of the Black Health Needs Assessment. It's the first time ever in Alaska that one has been done, and we're going to unveil that, share the results on June 30th, that's a Thursday at 6 p.m. at the Wendy Williamson Auditorium. And we actually completed this project in partnership with UAA Social Work. And so we're excited about it. We would love for you to come and hear the findings from that study. So thank you so much.
All right, thank you so much to Deanne and Celeste for sharing that information with us. And we'll make sure that our participants here tonight have access to the flyer for that session, so you can find out more information about that particular unveiling, as well as other activities and programs that the Alaska Black Caucus is taking a lead on. All right, so participants, whether or not you've joined in an Echo before, it's important to know that engagement with the group is integral to the all teach, all learn philosophy that underpins our program. We encourage everyone to ask questions and make comments during the session by utilizing the chat box, or when is appropriate by unmuting yourself and sharing directly with our group. You're also welcome to private chat myself, the session host, or any of our Hub team members if you'd like your questions shared anonymously. We're also happy to offer CME, AMA, PRA Category I, and Nursing ANCC credits for our series. In order to claim these credits, you must attend our live session and complete an evaluation, which will be linked in the chat at the end of our session. Once you've completed that assessment, you'll be redirected to a chat form where you can fill out and download your certificate of completion. Tonight's didactic presentation is by Dr. David R. Williams, the Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He's also a professor of African American Studies at Harvard University, and his prior faculty appointments were at Yale University and University of Michigan. Dr. Williams is an internationally recognized social scientist. His research has enhanced our understanding of the complex ways in which socioeconomic status, race, stress, racism, health behavior, and religious involvement can affect health. He's the author of more than 500 scientific papers, and the everyday discrimination scale that he developed is the most widely used measure of discrimination in health studies. Following Dr. Williams, we'll have an opportunity to hear reflections from our hub team of local subject matter experts, who will also lead us in an open forum discussion with our participants, exploring critical issues and visions for continued community and coalition building for the purposes of advancing health equity and tackling the public health crisis that racism presents. All right, so a few Zoom reminders before we get started. If your internet does not support audio, you can find a phone number to call in the chat box along with the meeting ID. Closed captions are automatically generated and are enabled by selecting the CC button at the bottom of your Zoom screen. We do invite you to take a moment to turn your camera on if you're able, so that we can all get to know each other. This is optional, of course. You can do this by selecting the camera icon on the lower left of your screen. And we do ask that you keep your microphone muted during our presentations and when you're not speaking. You can mute and unmute yourself by selecting the microphone icon also on the lower left of your screen, or by pressing *6 if you're calling in via phone. And to help further build connections and foster participation throughout our ECHO, we like to start each session with introductions. So we'll go ahead and hear from our hub team who've yet to be introduced, starting with Panna, if you would.
Good evening. Thank you very much. My name is Panna Lynch-Jerusi. My pronouns are she, her. My role in this process is as an Alaska Black Caucus Hub team member supporting the Health Equity Grand Rounds ECHO, and I'm here to learn and grow. I am a nationally board certified school nurse within the Anchorage School District, having served 5 years at Fairview Elementary and just finishing my 20th year at Robert Service High School. I'm also beginning my doctorate nursing journey at Purdue University, and my focus in that is operationalizing health equity for BIPOC and marginalized populations within the Municipality of Anchorage. This has fueled my passion for this journey and my progressive efforts with the Alaska Black Caucus. Thank you very much for your time.
Thank you, Panna. LaShonda, if you could share with us your introduction as well.
Sure. I'm LaShonda McGowan. My pronouns are she and her. I am an Alaska Black Caucus Hub ECHO member as well. That's how I am here. I am a social worker and a clinician for Alaska Behavioral Health. I love people. The reason that I'm here is to just gain knowledge. I certainly don't know it all. And also to share my perspective, to give knowledge from where I come from as a Black woman and as a therapist, where there's not very much representation. And so I just want to learn and grow and also share. And I'm really happy to be here.
And we're happy to have you. Thanks so much. Dr. Mandap.
Hi, hello, good afternoon. My name is Maddie Mandap. I'm a pharmacist from South Central Foundation Primary Care here on Denina land. My pronouns are she, her. I'm here as an ally, as a Filipino American queer woman. Happy to be here and learn as much as I can and support in any way I can. Thank you.
Thank you. And Dr. Alu.
Hey, good evening, everyone. My name is Obina Alu. I go by Obi, pronouns he, his. I'm currently a pharmacist transitioning to a legal career. Certainly think that the topics that these ECHO sessions have touched on are integral and imperative as far as building bridges and bridging the gap, if you will, as far as healthcare inequality and disparity. And as a Black male who has received healthcare in various settings and has also practiced as a pharmacist in various settings, I see the dire need for representation, for inclusion when it comes to a shared decision making, and ultimately taking steps collectively to make sure that healthcare is no longer something that race either determines or defines for people in the BIPOC community.
Well said. Thank you so much, Dr. Liu. And let's see, Thea, if you would.
Good evening, everyone. My name is Thea Agnew-Bemben. I'm a member of the Alaska Black Caucus and co-chair of the Health Working Group and a member of the Allies for Change. And I'm also one of the principals at Agnew-Beck Consulting. We do a lot of health and human services and health equity work and public health, behavioral health work around the state. And I have been excited and honored to be part of this series, as well as the other activities, the Black Alaskans Health Needs Assessment that Celeste talked about. There's just amazing work that the Alaska Black Caucus is doing right now. So thanks for being here, and I'm happy to be part of everything.
All right, thank you so much for those introductions, Hub team. And for our participants, feel free to also share in the chat with us your name, role, and organization, and again, what it is that you hope to receive from this ECHO.
Hi,
All
Aaron.
right.
I think I got skipped. It's Ken.
I'm so sorry, Ken.
Oh,
Yes,
yeah.
please introduce yourself.
Yeah, no
a critical
problem.
member of our team.
Thank you. So good evening, everyone. My name is Ken McCoy. It's definitely an honor to be here with you tonight. My pronouns are he and him. I'm a recently retired chief of police, and I currently serve as the chief diversity, equity, and inclusion officer for Providence, Alaska. And I hope that through these conversations, we can identify barriers and find solutions to bring true health equity to everyone. And although this is our final session, I'd like to say that the work is really just beginning. So I've learned a lot. I look forward to continuing to work with you all, and just thank you for having me.
All right, great to have you, Ken. And again, apologies for skipping you, completely unintentional, and appreciate your words. All right, a few final reminders before we get started. The opinions of our Hub team and presenters are their own and do not necessarily represent those of the Alaska Black Caucus, UAA, the Municipality of Anchorage, Anchorage Health Department, or any ECHO sponsors. Additionally, Project ECHO is not HIPAA compliant. Therefore, we ask that no protected health information is shared or displayed at any time. And finally, I want to acknowledge that the subjects that we're discussing carry weight, and as we will explore during this series, racism and its impacts are not abstractions. They exist materially, bodily, emotionally, and spiritually. As such, I invite those joining in on today's discussion to do so with that in consideration, to listen, to keep questions and comments on topic, to be considerate, and to use language that is respectful, especially when in response to those with lived experience and expertise. Thank you to everyone for following those guidelines. And with that, folks, I'm so pleased to turn our session over to Dr. Williams. Thank you so much for joining us, Dr. Williams.
Thank you so very much. I'm honored and privileged to be with you tonight and to share with you research on the topic of the challenges we face, but with an emphasis on what we can do about it as you move to that stage of thinking about what your next steps will be. I have a lot of territory to cover. I am going to share my screen. 1 second here. Let me share and unshare. I had it up, but then I demonstrated it and I didn't put it back in its right position. So here we go. So I have grouped my topic to fit what I think you're looking for this evening. I'm calling it the virus of racism, understanding its threats and identifying defenses. So I'm going to talk a little bit about some of the challenges we face, but also focus on the solutions and the opportunities we have to make a difference. I think the COVID-19 pandemic has grabbed the attention of the world. So far, over 1 million people have died from COVID-19 in the United States. That's equal to the population of Rhode Island and Montana, and greater than the entire population of 6 states, Alaska being one of them, but also greater than Vermont, Wyoming, North Dakota, South Dakota, Delaware, as well as Washington, D.C. So just the total impact on the US population is quite massive. If you could imagine an entire population of one of these states disappearing. And COVID-19 has shone a bright light on racial ethnic inequities in health. These are the age-adjusted odds ratios. Deaths through March 2021, so there have been a lot more deaths since then. But the pattern here continues, where you can see that the populations of color, the indigenous population, the Latino Hispanic population, the Black or African American population, the Native Hawaiian and Pacific Islander population all have death rates that are at least twice as high as those of whites. It's important that the point is clear that although the death rate for populations of color are higher than those of whites, the overwhelming majority of people who have died from COVID-19 are in fact white. One recent study found that when whites discovered that there were racial disparities in health, they stopped engaging, some whites, many whites, stopped engaging in protective behaviors because they felt they were no longer at risk. And you could see at this time of this study where, 520,000 people had died from COVID-19 in the US, almost 300,000 of those were white. So the rate of death and the numbers of persons who are affected are two different things that we should not get confused. COVID-19 has had a huge negative impact on the overall health of the United States population. From 2019 to 2020, for example, we saw a decline in life expectancy larger than we have seen since 1944. The life expectancy has declined for all population groups in the United States, with a decline of 1.1 years for white females, 1.3 years for white males, 3.3 years for African American males, 2.4 years for African American females, 3.7 years for Latino males, and 2.4 years for Latinas. So really massive declines in overall life expectancy. And these racial inequities we see with COVID-19 are not new. They have existed over time in the United States. And one way to illustrate that is to think of the life expectancy at birth for African Americans and whites from 1950 to 2020. Those are the only two racial groups we have data going back that far. And you can see in 1950, the average white person lived about 8 years longer than the average African American. So there was an 8-year gap in 1950. And you can see good news in the data, and that is life expectancy is consistently increasing over time, except for the decline from 2020 reflecting the impact of COVID-19. But prior to that, a consistent increase for whites and for African Americans. At the same time, we still see very large disparities in health. So in 2010, there was a 4-year gap in how long the average white person lived compared to the average African American. And in 2020, you see the impact of COVID-19. There's a 6-year gap, just not that much different than the gap in 1950, where there was an 8-year gap. Another way to think of these data is look at the life expectancy of whites in 1950, 69.1 years, how long the average white person lived. And let's ask, how long did it take for African Americans to catch up to the health that whites had in 1950? It was not until 1990, 40 years later, that African Americans experienced the health that whites had in 1950. These are stunning differences. It's almost as if you have one population living in a first world country and one population living in a developing country, where you see gaps in life expectancy of that kind of magnitude. So the question is, what drives these large racial inequities in health? My knee-jerk reaction would be to think of socioeconomic status. Whether measured by income, education, occupational status, poverty, or wealth, socioeconomic status, or SES, is a central determinant of the distribution of valuable resources in society, and in virtually every country where we have data, persons of higher socioeconomic status have better health than those who are lower in socioeconomic status. And race ethnicity is strongly related to socioeconomic status. So here's one example: median household income in the United States by race. This is 2019 report from the US Census Bureau. This is income in America in 2018. And I've just translated the data in a way that you can't miss the point. So I'm standardizing on the household income of whites as $1. And for every dollar of household income white households receive in 2018, Asian households receive $1.23. The Asian population in the United States is diverse, but it is heavily made up of immigrants. Almost 70% of Asians are immigrants, and they've come to the United States with high levels of education. The Asian population has more than twice the level of college completion, for example, than the white population. Importantly for these data, Asian households also have more persons contributing to household income, and that is, they are more likely to be in multi-generational households. So if I'd use a per person or per capita measure of income, whites would have the highest level of income. But let's look at the historically disadvantaged groups. In 2018, for every dollar of household income white households receive, Latino households receive 73 cents, and Native American and African American households receive 59 cents. What is stunning about the 59 cents figure for blacks, that is identical to the black-white gap in income in 1978. 1978 was the peak year of the narrowing of the black-white gap in income as a result of the anti-poverty policies of the 60s and 70s and the rights policies of the 60s and 70s, so the gap was reduced to 59 cents. And in 2018, the gap is 59 cents. Most of my students and most Americans think we have made a lot more progress than that. Has the gap been stuck at 59 cents since 1978? No, it got worse throughout the decade of the 1980s. Reaganomics was not good to African Americans, and it was not until the mid-1990s that it got back up to 59 cents, and it's been a penny up and down since then. The important take-home messages is that for many indicators of inequities, we have been on a treadmill and have made much less progress than most Americans think. And these large racial gaps in income that I just showed you markedly understate the racial gap in economic status. What do I mean when I say that? Well, income captures the flow of resources into the household, the salary, the wages that individuals have. But it doesn't tell us anything about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. And data from the Federal Reserve Board indicates that for every dollar of wealth that white households have, black households have 10 pennies and Latino households have 12 pennies. The challenge is, when you are low in income and low in wealth, we may all be in the same storm of the pandemic, but we are in different boats. And households that are low in income and low in wealth are less able to weather the storm, less equipped to manage the adversities that they, in fact, encounter. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in income and education. And therefore, if you compared African Americans and whites at the same level of income and education, race would not matter. We now know that life is more complicated than that. And to illustrate that, I will use national data for the United States, life expectancy at age 25, and I'll show the racial differences as well as the differences by education. The same patterns are true for income, but in the interest of time, I'll show you only the education data. So at age 25, the average white American lives 5 years longer than the average African American. So there's a 5-year racial gap. But here is the power of socioeconomic status. If you look within the white population, whites who have a college degree or more education live 6.4 years longer than whites who have not finished high school. And within African Americans, there's a 5.3-year gap between the best of African Americans in education and those who have not finished high school. Importantly, these data, and this is not true just for life expectancy, it's true for most health outcomes. The socioeconomic gaps in health are larger than the racial gaps in health. So should we just look at socioeconomic status and forget about race? I would say not so fast. Why? Because at every level of income and education, race still matters. So, for example, white high school dropouts, national data for the US, live 3.1 years longer than African American high school dropouts. And the gap widens as education increases, with a 4.2-year gap between black and white with college degree or more education. And here is arguably one of the most stunning statistics I will show you tonight. National data for the United States. The best of African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have graduated from high school. So what do these data tell us? They tell us there's something about income and education that matter for your health regardless of your race. But they also tell us, disturbingly, that there's something else about race that matters, even after we've taken income and education into account. So what does America think is the cause of racial inequities in health? Well, I'll show you data from a national survey of Americans completed in 2018 by PRA. It's a major public opinion survey research company. And one of the questions they asked is, why are there racial disparities in health? And they asked Americans to report the answer to this question. Blacks would do as well as whites if they only tried harder. In other words, if African Americans only tried harder, we would eliminate all racial inequities in the United States. And so the question is, what percentage of Americans believe that? 42% of all Americans believe that simply hard work would solve the problem of racial inequities. Among Republicans, it's 72%. Among Democrats, it's 23%. By race, 45% of whites believe that hard work would solve the problem, 43% of Latinos, compared to 24% of African Americans. Within the white population, white males is more than half. Also more than half, 51% of whites who have less than college education, but among college educated whites and among white women, the numbers are less than half. So a substantial proportion of Americans think that inequities are simply the failure of African Americans to work hard. So the question is, what does the scientific research clearly say? What is the data? What's the evidence on why we see race mattering even after we've taken income and education into account? Well, there's a large body of work. I'm just going to give you a few highlights tonight. That racism and racial discrimination are alive and well, pervasive and thriving in America, and producing inequities on a large scale. So let's talk about the house that racism built. What is racism in the first place? Racism as a societal system. A system that is linked to other social systems, has been shaped by them, and reshapes them in powerful ways. This system categorizes and ranks population groups, devalues and disempowers some, and differentially allocates opportunities and resources based on whether you are viewed as inferior or superior. That system leads to negative attitudes and beliefs, prejudice and stereotypes, and it leads to differential treatment, that is discrimination, by individuals and societal institutions. But fundamentally, racism is a system, and the system operates through multiple mechanisms. And I'm going to talk about one of them, an upstream structural or institutional mechanism of racism called racial residential segregation, one that I studied, and I've documented some of its negative effects on health. This is a 2001 paper where I argued it was a fundamental cause of racial disparities in health, and we are kidding ourselves if we think we can, in fact, eliminate inequities in health if we don't address the problems created by residential segregation. Now, I'm not the first person to talk about the importance of segregation. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed that apartheid was exported or imported by white South Africans from the United States. In the early 20th century, white South Africans looked across the Atlantic and saw how well segregation was working in the United States, and they said, brilliant. We can introduce that into our country. Importantly, Sell argues that residential segregation by race was one of the most successful domestic policies of the 20th century in the United States. And someone says, why are you harping about segregation? What does segregation have to do with anything? Well, think of segregation like a burglar at midnight. It slips into the community. But once it shows up, valuables disappear, like quality schools and safe playgrounds and good jobs and access to a healthy environment and safe housing and good transportation and access to high quality medical care. In the United States, all of these desirable resources that can facilitate good health vary by where you live, vary by your zip code, vary by your neighborhood. Let's look at some empirical evidence. I'm going to show you the findings from 3 studies. This is William Julius Wilson and Robert Sampson, 2 of America's most eminent sociologists. They completed a study of the 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of blacks, and that because of residential segregation and its legacy, the worst urban context in which whites reside is considerably better than the average context of black communities. That was a 1995 study, so have things gotten better? Well, let's look at the work of Professor Dolores Acevedo Garcia from Brandeis University. She has created a neighborhood opportunity index, ranking every county in the United States on 29 different indicators of access for opportunities for children on the 5 different topics, like the quality of elementary schools, or the high school graduation rate, and the homeownership rate, and the median household income, and the employment rate, and the quality of the environment, the air, water, soil pollution, as resources for health, green space, healthy food. These are just some examples of the 29 indicators in this neighborhood opportunity index. And what Professor Dolores Acevedo Garcia did, she looked at the 100 largest metropolitan areas in the United States. And she said, what percent of all children of different races live in neighborhoods that differ in access to opportunity? So if we look, for example, at neighborhoods with very low or low opportunity, 2/3 of all African American children, 58% of Latino kids, 53% of Native American kids, compared to 1 in 5 white and Asian kids, reside in very low or low opportunity neighborhoods. On the other hand, who lives in high opportunity neighborhoods? Almost 2/3 of all white children and almost 2/3 of all Asian children live in high or very high opportunity neighborhoods, compared to 1 in 5 African American and Latino kids. In other words, neighborhood, place, is a powerful driver of access to opportunity for children across the United States. In fact, research indicates that segregation and opportunity at a neighborhood level in the first place is the reason why large racial ethnic differences exist in income and education in the first place. Is research by Professor David Cutler, an economist here at Harvard University. He used national data for the United States, looking at African Americans and whites, using fancy econometric models I cannot even fully describe, but he's able to show statistically, if you could, overnight, erase residential segregation in America, you would completely eliminate black-white differences in income, black-white differences in education, and black-white differences in unemployment. and reduce racial differences in single motherhood by 2/3. All of those striking, stunning differences are linked to opportunity at the neighborhood level. One more study, one more Harvard economist. This is Raj Chetty. He's done an intergenerational. He has taken census data from 1989 to 2015, looking at all Americans, and asked a simple question. Let's look at Black children of different races, and in this analysis, I'm focused on Black and white children. And he said, let's compare the earnings of those children who grew up with parents, Black and white parents, that had the same levels of household income. So he's controlling on parental income. How are the children doing in the next generation? And he found in 99% of census tracts in America, census tracts that are geographic areas, Black boys have lower income than white boys, even when they started out life with the same level of household income. Why? They're not working hard enough? No, they live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys in neighborhoods with good resources, but remember, this is only true of 1% of Black boys in America. So what is the point that I'm making? Is that the racial inequities we see in income and education and employment and opportunity that matter profoundly for life and health do not reflect a broken system. No, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. These inequities we see are not accidents, they're not acts of God, they're not random events. They don't reflect the hard work and failure, laziness on the part of populations. They demonstrate and illustrate the ways in which racism has produced a truly rigged system in the United States. And this segregation that I've talked about also affects access to medical care. It's a 2012 paper. I and other colleagues summarize the ways in which segregation leads to the concentration of Black and brown low-income populations with low levels of health insurance, with providers who say they are unable to refer their patients to the best specialists in their geographic area, to areas that have fewer pharmacies and pharmaceutical medication research shows are even more expensive, to areas where hospitals are more likely to close, and where, because of this lower level of access to care, there are delays in care and the receipt of suboptimal care. And what else segregation does? When you are low in economic status and you live in disadvantaged segregated neighborhoods, it leads to higher levels of exposure and greater clustering of economic stressors like unemployment or difficulty making ends meet at the end of the month, of psychosocial stressors like the death of loved ones, of physical and chemical stressors such as air pollution. So I've talked about structural upstream racism, with segregation just being one example, and showing you the pervasive pathways by which it affects health. That's only one mechanism. Let's talk about individual discrimination as a type of stressful life experience that also has negative consequences for health. Martin Luther King said in 1967 that discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. Now, Martin Luther King was not a researcher, but this is a hypothesis that could be tested. And some 25 years ago, I developed measures of discrimination. One of them called the Everyday Discrimination Scale. It doesn't capture all aspects of discrimination, but it captures the little day-to-day indignities. Being treated with less courtesy and less respect than others, receiving poorer service than others in restaurants or stores, people are acting as if they think you are smart, they are afraid of you, they think you are dishonest, they are better than you are. Just little indignities. The American Psychological Association used this scale in one of their annual studies of stress in 2015, and they found that 1/3 of Native Americans said they have experiences of everyday discrimination almost every day or at least once a week. That was true about 1 in 4 African Americans, 1 in 5 Latinos, and about 10% or 11% to be precise, of whites and Asians. So these are common experiences that are experienced at higher levels by populations of color. Now, what difference does these experiences make? Do these attitudes and beliefs and treatment matter for health? I'm going to show you on this slide findings from over 450 papers have been published from around the world, linking everyday. I haven't conducted all these studies, but many people have used this scale to a broad range of outcomes. Studies show that people who score high on everyday discrimination are more likely to develop metabolic syndrome, cardiovascular disease, breast cancer, type 2 diabetes, more likely to engage in health behaviors that leads to worse health, more likely to develop subclinical heart disease, like coronary artery calcification, heart rate variation, more likely to develop blood pressure, have poorer sleep quantity and quality, have multiple indicators of biological dysregulation like higher levels of stress hormones, shorter telomere length, higher rates of obesity, less engagement with the healthcare system, and higher rates of mental disorders and psychological distress. So this is just a few examples of the broad range of ways in which experiences of discrimination adversely impact health. And today we have studies from the United States, the United Kingdom, South Africa, Australia, and New Zealand that shows in all of these countries, when you look at racial differences in health and you statistically adjust for income and education, and there is a residual effect of race that still is significant after you've taken income and education into account, that effect is further reduced when you add a measure of self-reported discrimination. Yes, the stress of discrimination is having adverse impacts on health. Shouldn't surprise us. Chet Pierce was an African-American psychiatrist at Harvard University. In 1970, he wrote a paper that these assaults to Black dignity and Black hope, that's what he called these experiences of everyday discrimination. The scale didn't exist, but what he described was what the scale measures. He says they are incessant and cumulative. Any single one may not be gross. In fact, the major vehicle of racism in this country is offenses done to Blacks by whites in this sort of gratuitous, never-ending way. These offenses, and he coined the term, are microaggressions back in 1970. And then research indicates there are hidden ways in which stressors linked to race and racism adversely affect health. One study found that over 70% of African American women said they are very concerned that their children might be harmed by the police. And a study published in 2021 found that mothers of youth who were stopped by the police are more than twice as likely to report depression and anxiety-related sleep difficulties. Yes, what's happening to their children is affecting the health of the mothers. And here is another study I conducted with colleagues. We looked at every police shooting of unarmed Black people in the United States over a 3-year period of time. And we also looked at the mental health of the African American population in every state. And we found that every police shooting of an unarmed Black person led to worse mental health, not just for the family and friends of the person who was killed, but for the entire Black population in the state in which it occurred for the next 3 months. Yes, there are spillover effects of these negative experiences. And what's the consequences of all of this? Scholars are using the term accelerated aging or premature aging or biological weathering to describe what is happening. What research indicates is that if you live in a bad environment, your chronological age is not only telling us how long you've lived, but it's also telling us how long you've been exposed to bad environmental conditions and how physiologically compromised you have become as a result of those exposures. And research is telling us now that African Americans at midlife, in some studies 7.5 years older than whites who are the same chronological age as they are, in some studies 10 years older, reflecting the cumulative negative impact of the wear and tear of their bodies because of the psychological, social, physical, chemical and racism residential, occupational, and other environments. And the consequences of this is the earlier onset of disease. Here is data on blood pressure, one example from the CDC, national data for the United States. By age 50 to 64, 61% of African Americans have hypertension compared to 41% of whites. So I've talked about structural racism. I've talked about individual discrimination. I want to touch base briefly on discrimination within our culture, within our stereotypes, within the assumptions we have of each other and the negative consequences that has on health. In 2003, the National Academy of Medicine published a report in response to a request from Congress called the Unequal Treatment Report. That report documented there was racial bias in medical care. The question for the report, and I served in the committee, and the question that we were faced with was not, are there racial differences in access to care, but given access, are there racial differences in the quality of care that African Americans and other minorities received? And what we found was, yes, African Americans receive poorer quality care and other populations of color compared to whites. This pattern continues. In the interest of time, I'll show you just one study published in 2020 of 1.8 million hospital births in Florida. When cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. The disparity is cut in half when Black babies are cared for by a Black doctor. So I've talked about the problem. What can we do? Strategy number 1, we need to build more health into the delivery of medical care. What does that mean? First, we need to think of how we can ensure access to care for all. I want to share with you a dramatic example from the state of Delaware. The state of Delaware, a small state in the United States, in 2002 implemented a program to colorectal cancer screening for all persons up to incomes 2.5 times the federal poverty level. 2 years later, they added free colorectal cancer. They added a nurse navigator system. They added community health workers to visit, do outreach, let people know these services were available for them free of charge. And what has been the result? Here is the racial difference in colorectal cancer screening before the program was implemented. By 2009, the gap has been eliminated with increases in screening for African Americans and increases in screening for whites. Incidence rates refers to the number of new cases of colorectal cancer every year. Look at what happened. Dramatic declines for African Americans and for whites, and the elimination of the racial gap in colorectal cancer, or new incidence, new cases of colorectal cancer. And look at colorectal cancer mortality. This is the death rate for African Americans and whites in 2001. There is over 90% of the gap has been eliminated by 2009, with declines for African Americans that are striking and also declines for whites. This is a dramatic example. This will not work for every health outcome, but for some health outcomes, access to medical care can eliminate inequities in health. If we did this nationally, 4,200 fewer African Americans would get colorectal cancer each year, and 2,700 fewer African Americans would die each year from colorectal cancer. But can we afford to do it? Yes, we can. Do you know what the state of Delaware showed? The annual cost of the program was $7 million. The annual savings from the program due to reduced incidence of colorectal cancer and earlier diagnosis was $8.5 million. The state saved $1.5 million per year from implementing this program. Why aren't we doing this universally? High quality scientific evidence this works. We need to find and identify those health outcomes where access to care for all, ensuring outreach that everyone knows the access is available, it can make a difference. What else do we need to do? We need to diversify the workforce to meet the needs of all patients. I want to share with you a randomized controlled trial of 1,300 African American men. They took these African American men in Northern California, give them a coupon, and a $50 incentive to go to a nearby medical clinic for a healthcare screening. When they got to the clinic, they were randomized an African-American doctor or a doctor of another race. The study found that men who saw a black doctor were more likely to talk about other health problems, likely to do the screening for diabetes, more likely to get a flu vaccine, more likely to do the screening for cholesterol. In other words, they were much more engaged and benefited from the healthcare that was available when there was racial concordance, when they could see and be treated by someone that they could identify with. We face a huge challenge in this country. In 2014, there were fewer African American males in the first year of medical school across the United States than there had been in 1998. Yes, in the mid-1960s, 2.9% of all practicing physicians in the US were black. Today, 5% of medical doctors are African American, 6% are Latino, 0.3% are Indigenous. We have a long way to go. I want to share with you some good news. Another study from Northern California, looking at HIV/AIDS, documenting large racial disparities in the receipt of antiretroviral therapy, in the patients following through and taking the therapy as they were supposed to, and in the therapy in working in producing the result, the viral suppression that it was designed to do. However, the researchers found something intriguing. They had a cultural competence scale to all of the providers. And what they discovered was that when cultural competence was among a provider, regardless of that provider's race, there were no racial disparities. So what did a provider high on cultural competence look like? What did he or she believe? Those high in cultural competence were those who believed that family and friends were as important to health as doctors. Those who believed that social history contributed to how they care for their patients. Those who said they were familiar with the lay beliefs their patients had. Those who said they asked their patients about alternative therapies they used. Those who said they find out what their patients think is the cause of their illness. Those who reported they involved their patients in decisions about their health care. It doesn't tell us how they got there, but it gives us the profile of providers who respect their patients, who communicate with their patients, who listen to their patients, and who involve their patients as partners in the delivery of healthcare. And when those conditions existed, there is trust, there is respect, and there weren't racial disparities in the quality of care. What else do we need to do? We need to provide care that addresses the social context. The World Health Organization asks, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? Here is a report from the National Academy of Medicine. It has many ideas of opportunities that exist. You can find this online at the National Academy of Press. You can download it for free. Integrating social care into the delivery of healthcare, of ways in which healthcare systems and professionals can address the social needs of their patients. Let me give you a couple quick examples. The Medical Legal Partnership, born at the Boston Medical Center more than 30 years ago. A primary care pediatrician at the Boston Medical Center can refer a patient who comes to a number of specialists. One of the specialists is a lawyer. Yes, the hospital has on-site lawyers to solve problems in the lives of their patients. So imagine a mother coming with a child with asthma. And the asthma is secondary to the poor housing conditions in which they live. All the asthma medication in the world will not help that child to breathe symptom-free if they go back to live in the same conditions that caused the illness in the first place. But a lawyer who reaches out to the landlord and says, you're in violation of the Housing Code of Massachusetts and we will sue you, fix this problem in the apartment, can get results, and we can see improvements in the lives of that child with asthma. The Nurse Family Partnership is another example. This is a program that provides home visits by nurses to pregnant teen moms. Randomized control trials show this program not only saves money, although you're sending expensive, higher paid nurses to make home visits, it saves money, but improves outcomes for the mother, it improves outcomes for the child, and it literally saves society money. I want to give you one more example. Real practical one, and this is from a 1978 study from Len Simon in University of California, Berkeley. So this is not new. He took 244 low-income patients, 80% of them African American, randomly assigned them to 3 groups. 1, routine care. Go to your doctor, get your blood pressure medication, go on your merry way home. The second group, in addition to your medical care, you went to a class 1 night a week for 12 weeks. A public health person taught you about the importance of high blood pressure and taking your medication and what you needed to know. The third group, they got lay people from the local community, not professional health workers, and provided them basic information on blood pressure. But they also provided them with information about the resources that existed in the community to help people with problems they face in their lives. And these lay workers made home visits, and they talked about blood pressure, but they also referred people and pointed them to resources that existed to help them. 7 months later, those who got the lay conversation with people with the home visits were more likely to have their blood pressure controlled than patients in the other 2 groups. Second, they knew more about blood pressure than patients in the other 2 groups. Third, they were more faithful in taking their blood pressure medication, and among those who were taking it as it were supposed to take it, the medication itself was twice as successful in controlling blood pressure. What's the difference here? That third group, their high blood pressure was understood and addressed, not as an organ system that was sick, but within the context of their lives. And the more that we can treat our patients that way, we improve the quality of their lives and we enable them to improve their health. So we need to build more health into medical care. What else do we need to do? We need to identify and support protective factors and resilience resources. Let me give you one example by talking about the power of social relationships to, in fact, enhance health. Gene Brody is a researcher in Georgia. He has been studying African American teens in 9 rural counties. He has assessed discrimination in these kids at age 16, 17, and 18. And he has documented that those kids who were stably high on discrimination as a teenager, so at 16, 17, and 18, they scored high on discrimination. By age 20, I didn't say age 40, I didn't say age 30. They are high on discrimination as a teenager. By age 20, higher stress hormones, epinephrine, norepinephrine, cortisol, higher blood pressure, higher inflammation, higher BMI by age 20. However, the relationship between discrimination and biological dysregulation is broken among those African American teens who were embedded in positive, good social relationships with their family, with their friends, with their teachers. High social support erased the negative effects of discrimination on health. And one of the things we need to do for our teenagers, we need to create environments where they can interact with adults who they can talk to. I didn't say who talk to them, but who they can talk to and who they can trust. In other words, who will listen to them. We need to stay engaged with them and help them to be engaged in service to others. I'll show you in a minute why that's so important. We need to create safe spaces where we can hear from them, where we can validate their experiences, when they can be assured they are not alone, when we can point them to resources that can help them to cope. Here is a study I published a long time ago, the first study I published on religious involvement in health. It was a study of adults in New Haven, Connecticut. The stress they faced and the life events and health problems that they faced. And we found, following them over 2 years, people who had high levels of stress and lots of health problems, their mental health got worse from baseline to 2 years later. However, among those who attended religious services frequently, church attendance reduced the negative effects of these stressors on mental health. Another example, National Study of African Americans. Exposure to racial discrimination adversely affects their mental health. But 3 aspects of religious engagement: frequency of attendance, church-based support, receiving support from others at your place of worship, and seeking religious guidance in their everyday life, reduce the negative effects of experiencing on mental health. A final example of a resilience, and these are not an exhaustive set of resilience factors, but here's another set of factors: protest, advocacy, and empowerment. This comes from a study of Native youth in Canada. At the time of this study, these youth had one of the highest levels of youth suicide in the world. But this study found, looking at 196 First Nation communities, that half of them had no youth suicides at all. The group has the highest rates of youth suicides, but half of the communities don't. So the researchers said, what's the difference? How do we understand what's different about those communities that have youth suicides from those that didn't? And they identify 5 indicators of challenging the government of Canada for titles to land, for the right of self-governance, for control over their services like fire and police and education, and having a building in their community where they taught young people their culture and their history. Each of these indicators of advocacy, protest, empowerment, and cultural affirmation was associated with a lower risk of youth suicide. Yes, getting our young people involved in advocacy, protest, empowerment, and cultural affirmation can be a health protective strategy. But we need to move further upstream if we are going to address improving health and reducing inequities. It's more than medical care and coverage and access and affordability. We need to think of how we improve living and working conditions and the social and economic opportunities and resources for them. I have written that we need to create communities of opportunity to minimize, neutralize, and dismantle the systems of racism that have created inequities in health. What do I mean by that? Well, we need to enrich the quality of neighborhood environments. We need to increase economic development in poor areas. We need to improve housing quality and the safety of neighborhood environments. Here are just some of the strategies that we can implement: investing in early childhood, reducing childhood poverty, improving neighborhood and housing conditions. Let me just highlight a few of them quickly. Here is a study done in North Carolina called the Abecedarian Project. It took poor kids, 80% of them African American, at birth, randomized them to an early childhood program. They were placed in a clinic where they got good, nurturing care, good nutrition, good intellectual stimulation. Birth through 5 is the program. Then they have monitored the kids over time. By the mid-30s, those who got the program have lower levels of risk factor for cardiovascular disease and metabolic disease. Here's the blood pressure level, systolic blood pressure level of the treatment group, those who got the program, compared to a control group, kids in the same neighborhood without the program. Dramatic differences in risk factors for heart disease in the mid-30s linked to what happened to them birth through 5. We need to enhance workforce development, broad range of strategies, mentoring elementary school students, creating internships for high school students, creating job opportunities and pipeline programs to be health professionals, providing pathways of success for employed individuals. All of these are health enhancing strategies. We need to improve neighborhood and housing conditions. There is studies that show, take poor people, simply change the neighborhood, no health intervention, health is improved simply by improving the neighborhood. Is it possible to do this? Yes, we can. I want to give you a striking example: purpose-built communities. And the first purpose-built site was in Atlanta's East Lake District. Come with me to the villages of East Lake Meadows in 1995, an African-American public housing project where 90% of the families who lived there were victims of a felony every year. Dilapidated public housing, only 13% of adults employed. The elementary school, one of the worst performing in the state of Georgia. come with me to the villages of Eastlake. They tore down the public housing project, and in a collaboration with the public housing project, the housing office, public housing office in Atlanta, and a wealthy philanthropist, they have created the villages of Eastlake. There's been a 90% reduction in violent crime. There's high quality privately managed housing. All able-bodied persons are employed. And the school, even though 60% of the students qualified for reduced price lunch, is one of the best performing elementary schools in the entire state of Georgia. The purpose-built model shows it can be done. We can address all the challenges faced by poor communities simultaneously. Yes, we can implement integrated place-based solutions. Yes, we can develop a high-quality cradle-to-college pipeline. It is possible if we only put our minds to it. I want to point out that there are innovative initiatives from healthcare institutions, and I'm going to give you one of them quickly. The Rush University Medical Center is an academic medical center in Chicago, Illinois, and they have decided that they will reduce life expectancy among African Americans who live in their service area and the rest of the people who live in their service area in their large gaps. They will reduce them by 50% in 10 years. And what will they do? They will invest locally. They will invest in the local community, give employment preference to people from the community, use local labor for the projects, develop career ladder development initiatives for kids in the elementary school and high school, develop apprenticeship initiatives to get local people to get jobs within the healthcare services. When they need to purchase supplies, buy them locally. Increase and develop a financial literacy program for the local community. Incentivize their employees to volunteer with local community organizations. They have truly become an anchor institution in the community, transforming opportunities for their entire community. So why do we need to act now? I want to quickly, before I close, tell you about the reasons why we can't wait. Because we are paying multiple costs. The earlier disease and premature death is leading to the loss of life on a large scale. Compared to whites, because of racial disparities in health, Black children are 3 times as likely to lose a mother by age 10. Black adults twice as likely to lose a child by age 30 and a spouse by age 60. And this loss of social ties, I've talked about the power of social ties, has negative effects. Another reason, these racial disparities in health reflects 220 Black people dying prematurely every single day. Imagine a fully loaded jumbo jet with 200 passengers and crew crashing every day and dying. That's what's happening in America when we say there are racial disparities in health. Why else we can't wait? It's costing the U.S. economy $309 billion is the cost of racial inequities in health to the U.S. Economy. And one final reason, the most powerful of all, how this is affecting our kids. Here is a study that looked at suicide rates among elementary school children from 1993 to 2012. I'm talking about elementary school children aged 5 to 11. They found the suicide rate was stable overall, stable for Latino and Asian kids, but had markedly declined for white children and doubled for African American children. A follow-up study found up to age 13 for Black boys and girls, 5 to 13, the suicide rate is twice as high as for white children. These data beg 2 questions. They tell me, or make me ask the question, force me to ask the question, what does it feel like to be a Black child growing up in America today? And what are we going to do about it? Why Black children dying at this high rate committing suicide? A study published last month, May of 2022, of 11,000 children found that African American children, mean age 11, report the highest levels of discrimination and the highest levels of suicidality, and that when you adjust for discrimination, race doesn't even matter. So it's not race that's driving the discrimination, the higher rates of suicide. It is the discrimination that the kids are experiencing that are driving it. What are the barriers we have to address? We need to raise awareness levels of the challenges. Most Americans don't know of these inequities we've talked about. We need to develop political will, and we need to build empathy. I want to conclude by saying it's so important as we move forward to raise awareness levels, to build empathy, to build political will, that we make the point that the creation of these communities of opportunity to reverse racial injustice will be beneficial to people of all races. Policies that will benefit communities of color will improve conditions for everyone, including for many poor working class whites. And remember, there are more poor white people in America than poor African Americans. There are more poor white people in America than poor Latinos. And these are policies that will help everyone. I leave you this evening with two quotations. One from Martin Luther King. He said, "True compassion is more than flinging a coin to a beggar, but it understands that an edifice which produces beggars needs restructuring." I've spoken tonight about edifices that produce beggars. And finally, the words of Robert Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It is my hope that each one of us tonight would recommit ourselves to be a tiny ripple of hope. And together we can build a current which can sweep down the mightiest walls of oppression and resistance in Alaska and across the United States. Thank you so much for your time and attention this evening.
Thank you so much, Dr. Williams. That presentation was so incredible, very insightful, very powerful. I would like to open the floor up for any questions or comments that our participants may have. If you do have a question or comment, feel free to unmute and introduce yourself and ask your question. And you can also put questions in the chat.
Don't be shy. There's no bad question. There's no stupid question. That's what I tell my students all the time. So any thought that crossed your mind or anything you want me to clarify, happy to address.
Hi, Dr. Williams.
Yes.
My name is Obi, currently a pharmacist, transitioning to a legal career. And one of the things I wanted to ask that you touched on in your presentation was regarding representation in healthcare. When it comes to better outcomes when people receive care from those that are reflective of the community in which they're in. And so for a lot of people that are pursuing healthcare careers, a lot of the stressors that you mentioned are profoundly heightened, I would say, as they matriculate through the academic journey, whether it's the didactic or clinical portion. And is there any advice or ways that you would give people in that unique position to better navigate or handle those personal stressors that they face to be able to overcome and be in a position to hopefully then positively impact the discussion that we're having?
Thank you so much for that question. It's really, really a very important one because you're absolutely correct. The underrepresentation, I showed you the data in medicine, but medicine is not. You see similar data whether you look at nursing. I have data on pharmacy as well, didn't bring it, and speech language pathologists. You go across the health professions, you see it. Minorities, African Americans, Latinos, Native Americans are dramatically underrepresented in all of these professions. And yes, it does make a difference who is providing care and the orientation that that patient provides in the delivery of care. So yes, we do need to make it as a priority if we are truly committed to equality and to healthcare system, to change the persons who sit around the table, to change the makeup of the persons who are providing care. It will help to build trust within the communities and within our communities, and it will make a difference. So yes, I would say one of the things that is important, even when the numbers are small, and what facilitates survival, is in fact, I talked about the power of social relations, the social ties, support groups. I can think of when I went at the University of Michigan, the minorities, underrepresented minorities were a small number within our cohort, but we came together and we called ourselves the family. It was 3 Americans, a student from Hawaii, it was 6 of us. And we called us the family, and our motto was, "It's going to fall through the cracks." And I can remember the first year in graduate school when we would spend 20 hours a week just working on our graduate statistics exercises, because the program was very heavily quantitatively focused. And, I would say we would bring all the knowledge we had together. We sat around the table, and as all these homework assignments, there were things I didn't remember, but someone else, that person forgot that I understood. And as we put our minds together, we all survived, we all did well. And the notion of building that kind of support network, ideally within your program, but if not, with technology. I went to school in a time when there was no internet, there weren't cell phones. In this world in which we live, all of these things are so much easier now. So, and importantly, sometimes we tend to think as I'm not just first generation college, I'm first generation high school. My mother and father didn't go to high school. Okay, so I was really trying to navigate myself down a path that I didn't exactly have good direction and guidance for. And it's easy to doubt yourselves and to think you are not capable, or to have imposter syndrome. These are normal things for persons like mine, but it's about recognizing that we can help each other, that we can support each other, that we can make the doors that are open for us. And of course, there needs to be a commitment to work hard and to put in the time and effort. That goes without saying. But I think the building the networks of support and really mentors, say I good mentors as well, that can really make a difference. But there's nothing like social support, and I think it's so much easier to set up those systems now than it was even when I went to graduate school. But great question.
So, Dr. Williams, you've
Yes.
given us a lot to think about here, and it's really clear to me that it's going to take community coming together and buy-in to really make progress. So can you share with us how can we improve that buy-in from our stakeholders? When we send out invitations and for outreach and engagement, and we don't get a response from our major stakeholders, it really sends a message that reflects on where we stand with delivering quality care within our community. Can you share with us what can we do to get better engagement and get the right people at the table to help make progress here?
Really, really great question, and a vitally important one. Let me give you a personal experience. Before I went to graduate school and did my PhD, I earned a master's in public health, and I worked as a community and employee health educator at a hospital in Battle Creek, Michigan. And the hospital that I worked at was located surrounded by an African American community. What had happened over time, the community had changed. It's a hospital had been there for a long time. In fact, it's a hospital where Dr. John Harvey Kellogg invented cornflakes and coined the word granola. That's how long it went back, and had this emphasis on preventive health and improving health. But it was now surrounded by an African American community, and we had a number of programs. And even when we tailored programs, I'll give you an example. My supervisor, an African American public health, she was a nurse and with an MPH. She went to Africa and discovered secrets of how our ancestors lived and ate in Africa, and how they used natural foods and didn't use all these refined products we use today. And she came back and had a seminar that was heavily advertised and publicized in the local community and the newspaper and the television. And she called it the roots of soul food. And the majority of people who came to the program were white. And I ran a blood pressure clinic and all these programs, and the majority of the people who came to the hospital, I'm saying the hospital is in the black community, were white. Now, there was a church 2-3 blocks away. It was the center of the African community. Reverend Bullock, an AME pastor there. I went and visited him, introduced myself as a new team member and what was the services I offered and how I wanted to reach out to the community. And he told I can come to church any Sunday. He would give me a few minutes in the worship service to come to the community, and I went the next Sunday, and he gave me time, and I got up and spoke to the community and talked about health and how important it was and all the things and services that I had and wanted to come, and I got wonderful amens and so forth, but nothing changed in terms of who was showing up at the clinic. And one day, sharing with another public health educator, working with an African American community, and she said to me, and it was a profound insight. She said, we need to go, what she had discovered in her work, we need to go where the people are and don't wait for them to come to us. And so she had developed an effective program by going to churches on Wednesday nights, where people were going to the Wednesday night prayer meeting, and set up her stuff before the prayer meeting, and she was now reaching people. And a light bulb went off, and I thought, you know, Reverend Bullock's church, he had all these African American seniors and other people coming to 2 days a week. He would serve lunch, and there would be 60 people coming to his church for lunch. So I moved my high blood pressure clinic from the hospital, set up some tables in his church and outside that community room, and I was now screening 20 to 30 African Americans every time I went and talking to them about hypertension and what it was important to do. But you see, I was before doing it convenient for me, sitting in my office at the hospital and expecting them to come for me and thinking because it's a free service, then they should come, as opposed to going where they were, building trust, relating to them, and having them really engage with me, get to know me as a person. And I had a very good relationship with them and had a lot of programs, but I completely flipped the model, the script that I had of expecting them to come to me. And just because I told them at church about it, that's enough for them to show. Our people have gone through a lot in their lives and have, not always been treated with dignity and respect, and have been sold bills of goods that were not in their best interest. So they have a healthy skepticism and are careful, and that's why they have survived. And I think we need to think of how we really begin by building relationships and meeting people where they are. Can I give you one other quick example? I ran several years ago the Robert Wood Johnson Foundation's Commission to Build a Healthier America. I was a staff director. And we were looking at success stories across the country. And one of the things we looked at in the state of Pennsylvania was they had developed a food financing initiative where an African American member of the state house had allocated over $10 million a year for 3 years, gotten the legislature to allocate $30 million to an initiative that would develop supermarkets, full service supermarkets in urban underserved areas as well as in rural underserved area. And we visited one of those areas where there was now a 60,000 square foot supermarket in an African American community, median income under $30,000, where there had not been a supermarket in 25 years, and the supermarket was doing well. And I walked into the supermarket with the owner of the supermarket, who was a white male who owned 12 supermarkets in the greater Philadelphia area, but he owned, this was one of 2 that he owned in poor African American communities. And as I watched it how he related to people. He knew the people. He owned 12 supermarkets. He knew these people by name, most of the African American staff. He was hugging people left and right. And then as we walked down, he showed me this is the deli and this is the halal approved deli for the Muslim community. I walked around the corner. This was the African food section, and then there was the Caribbean food section. And then he showed me this whole aisle of cosmetics, this halal approved cosmetics. And I mean, and I turned to him and I said, what kind of consumer research did you do? How did you so tailor your supermarket to the needs of the community? He said, I didn't do any traditional consumer research. It wouldn't have been helpful. I said, so what did you do? He said, I worked with local leaders in the community and I had them nominate people in the community whose homes I could go to and have dinner with. And he says, I went to their homes, had dinner with them. I was very observant and asked a lot of questions. And so he tailored his store to the needs of the community. And just to give one other example of what he did, the 2 supermarkets in these Black communities had a community room, and we went into the community room and had a meeting with local community residents in that room. And they said to us, you know what, Mr. Brown, his name is Jeffrey Brown. He said, Mr. Brown, all they have to do to have a meeting is just come and reserve it. It's free, no charge. You can have a meeting, any group can have a meeting in the community. You just need to come and reserve it ahead of time. And they said, when we come, he has refreshments available to us. And one last thing about Mr. Brown, but it just shows what's possible. Here he had 240 employees in this supermarket. 60 of them were ex-offenders, persons with a criminal record. He worked with 2 local community organizations to improve their skills and build their aptitude so that they would be successful in his business. In fact, one of the things he told me was that he explained to me, he told me that he needed help from the Food Financing Initiative because his training costs for these urban underserved areas were high. And I said, I don't understand. Why are your training costs higher? He said he has to put more time and effort into training. Many of these people had not held down a job, and they operated by what he called the rules of the street. The rules of the street are, you're nice to me, I'm nice back to you. You mean to me, I'm mean back to you. And he said it took more time, more training to help them to understand the customer is always right. They're mean to you when they shouldn't be. They're accusing you of stuff you haven't done. Smile, be nice, and so on. But he found he had a high retention rate among his staff, and people were very successful, but it took more training than he typically had to do in his suburban supermarkets. My point is, I'm just giving you illustrations of we have to engage with community, we have to meet them where they are, and we can develop these successful relationships with them. That was a long answer. I apologize. It was that long.
No, that was perfect, That was perfect, Dr. Williams, and it really touched on some of the questions in the chat. Dr. Sonia Hunt had asked about building trust with the community, building trust between the community and institutions that have historically, underserved our African Americans and the other minorities. So I think you really touched on some steps we can take to build that trust. And Aaron, I'll go ahead and pass it back over to you. But thank you so much, Dr. Williams.
You're welcome.
Yes, Ken, I was just wanting to share with the rest of folks, because 6:30 is technically our time. So for folks who are looking to receive CME and nursing credits, there is a link in the chat. However, we can take a few extra minutes to close out this conversation with some critical next steps, in particular with connecting with ABC's present initiatives and some important notes about what it means to be a true and effective ally in addressing racism as a public health crisis. And also some time for some needed reflections from our hub team as well, some brief takeaways. So Ken, I'll turn it back over to you for that purpose, if you wouldn't mind sort of guiding us through a truncated bit of a group discussion here.
Thank you, Aaron. And yes, this series was amazing, and there were many, many takeaways. And I think I'd like to share with you some of what I learned, and really open it up to our other hub team members to give you some of their thoughts. But briefly, for me, the entire series was incredible. And so it's difficult to really identify one presentation or takeaway. However, we all know that healthcare disparities have impacted people of color and other minority groups at alarming rates. And although we knew this going into the series, my eyes have been opened even wider, seeing the data, reviewing the case studies, breaking down the history, has created a sense of urgency in me. We must take action to improve affordability, access, and the quality of treatment for all, but especially for our Blacks and African Americans. So for me, as I mentioned during the introductions, although this is our final series, this is just the beginning. And I think we need to, as Dr. Williams stated, meet people where they are, deliver our services to them, not sit back and expect them to come to us. And we're going to have to work together, and we're going to have to find ways to get the stakeholders, the people who can make the political, financial, and social decisions within our community to the table, and get their commitment to truly addressing the needs of our BIPOC community. So thank you. It's been an honor for me to participate in this series, and I'm going to go ahead and turn it over and open it up to our other hub team members for some thoughts on the series from their perspective. So if any of you want to just come off mute and give us your thoughts, that'll be great.
Hey, Ken, thanks so much for opening it up. I echo what everyone said. I feel like this series has been profoundly insightful. And I even being a healthcare professional, I've learned so much and taken away so much as a person that is in healthcare and is also a minority or African American. And I definitely want to thank Dr. Williams for such a spectacular presentation. The delivery and the content was exceptional. And it really highlighted, I think, in multiple different angles, ways that people can help conceptualize and wrap their mind around the disparity in healthcare conversation, and gave tangible ways that we can make progress, and I think collectively. So I just want to thank everyone for being a part of this. I want to, definitely say that for all the participants that have called in, hopefully they taken something away that is useful in their practice setting or in their institution. And hopefully, like Dr. Williams said, we can all be the small ripples that can create the mighty current. So thank you so much.
Hello, this is Panna Giarrusi, one of the Hub team members, and I am speechless with this last presentation. It is awesome. Awesome. I have been a BIPOC advanced practice school nurse in a district with 110 nurses, and I'm only 4 of these nurses are BIPOC, and I'm one of those 4. And your presentation, Doctor, today gave me a path to take going forward. And I just learned that, which is powerful, the CDC has recognized school nurses as integral to a community-based asset to health promotion and disease prevention. And they have funded specific initiatives for school nurses to support health equity. This just happened June 6th. So that information and the information from this presentation has given me even more motivation and power to go forward and do good for BIPOC and all children within the Anchorage School District. So I want to thank you immensely.
Hi, I'm LaShonda. And just listening to your presentation, I could have just cried. I'm just thinking this is so much good information, and you can't argue with the data. Like, here's all these facts over all the years that you just cannot fight with. And so it's just, I don't know, I just feel empowered. I feel like even though when I'm tired and I don't want to educate other people, I'm gonna do it anyway. There may be people who don't want to know, who don't want to learn, who don't want to make a difference, but that's okay. I will just continue to do what I need to do to be my best. And here I go, getting all emotional again. Thank you.
Thank you.
Hi, this is Maddie here, pharmacist. I just wanted to echo everybody and just share that this was Dr. Williams, your presentation was the perfect ending to this amazing series. Thank you so much. This personally is very eye-opening to me, where, you know, I see science as it's supposed to be objective, but no, like racism has been sewn into the fabric of so many systems, not just science and healthcare, but everything else that you talked about. And it's just a really good reminder to reevaluate, you know, be introspective, not just about your intrinsic bias, but look around at all the systems you're involved in, and to find the ways that you can be a ripple and to recruit allies so that you can help create that current. One of the questions that I don't know if there's an answer is that, you know, representation is really important, BIPOC representation specifically, and how do we center BIPOC people and increase participation without contributing to what we learned before, racial battle fatigue. In other words, making BIPOC people do all the work. And I think it's just really important. And how do we recruit allies who might be suffering from compassion fatigue, and not just from, you know, racism related things, but COVID and everything else that's happening nowadays. But thank you so much for allowing me the opportunity to participate in this.
Ken, I can go
Thanks.
next if you want.
Yes, thanks, Dia.
Yeah, great. Thank you so much, Dr. Williams. This was an amazing end to an amazing series. And, you know, as you walk us through all the data that you shared, I guess for me, and just exactly what Maddie just said, I guess I feel frustration that actually there aren't more people who identify as white who are as, I mean, just how can you look at that data and not be just so ashamed and absolutely motivated to change it. I mean, I think really, like, actually the data that you showed about where kids are growing up, and that 2/3 of white kids are growing up in, what you call sort of high resource environments. I mean, I think in some ways, the problem in our country is that for many white people, the impacts of racism are just not visible. And it's shocking that that's the case, but I think it is. And then when it becomes visible, people react with a feeling of shame and they want to turn away. And so but I mean, if we all call this country our home, like, how can we not want to change what you just showed us, So I guess for me, I feel very just super grateful, actually, just that I've been able to be part of the Alaska Black Caucus over the last couple of years, and was welcomed by Celeste and others, and have gotten to be part of the health committee and learn a lot through that process, and also just make new friendships and relationships. I think that's one thing we were just talking about last weekend at the Juneteenth, is just how, or maybe it was the weekend before at the health fair, I think, where our communities just are like little islands, and we're not really reaching out to each other enough. And so the more that we can make those professional relationships, friendships, and work together over a long time, I guess, as far as being an ally, I think, as long as you're willing to just stay in it for a long time, and, like Allison was saying, just answer your email, like show up when asked, be there, be real. Really, that's, and there are so many opportunities in all of our environments to address racism and to dismantle systemic racism. I just think it's just a matter of starting to really see those opportunities, and then being, brave about doing it. So I don't know if that helps at all, but Celeste, I'll hand it over to you.
So thank you, Thea. And I'll be quick, but Dr. Williams, I just have to say, hands down, the best. I mean, way to close us out the series. Thank you. Thank you so, so much for this. I am just in awe of a lot of things that you shared, but I do want to go back to LaShonda. And I have to say that when we're doing this work, it's so exhausting. And I picked up on her because she resembled me. And when we start talking about this, we tear up. It is just that emotional for us. And you talked about stress. And I'm just wondering, is there anything that you can offer? I know we're late, we need to close this out. But I just have to ask, can you just shed some light on why it is we tear up? And Thea, oftentimes during conversations, when we're talking about race, I do the same thing. In fact, I'm doing it now. So what can we do? We've got to keep telling our story.
So can I just make a quick comment? Thanks for all of your kind words. I think what my take-home message from what you're saying, it's highlighting one of the critical steps that as a group you have come together, that you need to figure out how you will do more of, is educate. What I shared with you tonight, it's published evidence that's out there, but most Americans are not aware of it. So we need to find ways, even within our local communities, that we can facilitate education. Statistics are good. I'm talking to a highly educated audience, so I heavily focus on evidence. But generally, in working with community, what's much more powerful than statistics is narrative. It's stories. Find examples that illustrate it, and then you tell them there's data that supports it. But what gets people's attention, and what also gets even policy makers' attention, you have a chance to do a congressional briefing, tell a story, and then show them there's data in support of it. But what grabs people's attention, story, is narrative. And importantly, what you are saying that is very profound, and one of the things that's lacking a lot in conversations about race in this country is empathy. We don't feel compassion. W.E.B. Du Bois, 1899, Philadelphia Negro, has a chapter in that book on Negro health, and he shows the statistics of the black-white differences in health in 1899. And as he comes near the end of the chapter, he says the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And he goes on to say there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. And he's saying the fundamental challenge of racial inequities in health is Americans do not care. We don't feel it. So you feel the pain, you are moved to tears. That's wonderful. You are identifying with the challenges that are out there, and you want to make a difference and turn those tears, let them flow, but let them be a source of inspiration and a source of commitment to continue to do this work and the value of this work. But let us also find those narratives, those local stories that we can showcase to people in our community so that they can begin to identify emotionally. That's the problem. People don't know, and they don't care because they don't understand, and they don't identify with the challenges, and they have misconceptions of what the underlying drivers are. So I hear a lot of hope. I get a lot of hope from what you are saying. I've been doing this for some decades now, and I do get hope from my students who are so committed. I do get hope from audiences I speak to who are committed to move forward and make a difference. And really, yes, we all together can be ripples of hope. And we have to be, because we cannot continue the way we are going, so that we can provide a better future for all. Let me leave one last thing. Why we need to help people, other people, why white people need to be engaged. Come with me to 2060. In 2060, for every person receiving Social Security, there'll be only 2 people paying into it. When Social Security started, there were more than 15 people paying into Social Security for every person receiving it. But in 2020, when 2060, there'll be 2 people for every person receiving Social Security. One of those 2 people will be Black or Latino. They are in kindergarten now. If we want Social Security to be there for us and to support us when we retire, we need to do everything we can to ensure those Black, Native American, Latino, and Pacific Islander kids get the best education, develop the best skills, can be the productive workers, so that they will keep the Social Security system alive, so that we can receive Social Security. It's in our own actual financial interest, not only now, but in the future, to ensure success for everyone, because all of us will benefit.
Thank you.
All right, thank you so much, Dr. Williams, for being with us over time. Celeste, the rest of our hub team, we talked about critical next steps and invitations to our audience on ways to continue to engage here in Anchorage and beyond, specifically with the Alaska Black Caucus's initiatives. And I just wanted to give you an opportunity to speak to anything directly that you'd like to impart with our participants.
So I just want to reiterate, I know we've said it several times already, the importance of this work not taking a pause, that it must continue, even though this series is over. It is too important. And so I just want to invite everyone to stay engaged. You can visit us out at the alaskablackcaucus.com for more information, and then to re-invite you all to the Health Needs Assessment Study unveiling that's happening on June 30th at 6 p.m. at the Wendy Williamson at the University of Alaska Anchorage. And so thank you. This has been great, but there is more to come.
And if I may, if I can just piggyback off of that, and I'll keep it very brief, but what I will say, and this is going to be specifically to the other BIPOC members, professionals, Hub team, and also in the audience. Several individuals have asked as far as how we deal with the stress and how we continue to fight the fight. And what I will say personally is continue to be that example, continue to change the narrative by your personal life, your accomplishments, and the spaces that you've earned your way to, and continue to shine the light on these issues. But I think in doing it through your work and through allowing yourself to be a reflection to those around you, especially those in the community who at times might not see many individuals that look like them, that are you. And so I just want to personally encourage everyone to continue to charge the hill, if you will, for lack of a better term, and just know that collectively we will all reach a point where, maybe not in our lifetimes, but these issues will be things of the past. So thank you.
All right, thank you so much, Hub team, Dr. Williams, and our participants, as always, for helping us shape and drive this discussion. It has been an incredible gift to help support the Alaska Black Caucus's vision, in this endeavor. And so I just want to express my deep gratitude and thanks for being able to participate. For those who would like to learn more about the ABC's initiatives, there are links in the chat. And if you missed part of this session or others, you can always check out the box folder, also linked in the chat, where you can find recordings of previous sessions and resources shared during, including slides, articles, etc. Again, I look forward to seeing you out in the community, continuing to charge the hill, as Dr. Alou mentioned, and sending out those ripples, as Dr. Williams so eloquently put. Again, my thanks, and have a wonderful evening, folks. For our Hub team, if you have a few minutes, I'd love to do a quick debrief. Dr. Williams, I know it's late on your end, so no obligation to join us, but you're welcome to, of course. Thank you again.
Thank you.